which will say share towards the right hand corner of your screen.
I don't seem to have a share on my screen at all.
You don't have?
Let me just. So share screen. Yeah. Okay. Sorry. Yeah. Getting there.
Yes. Now we've started seeing. Yes. Yes. We can see.
Yeah.
Yeah. Yeah.
Okay. That's fine.
Great.
I'll minimize mine and then Barney can go.
Sure.
So you'll have to stop sharing.
Okay. Stop share. Yeah.
Yeah.
I'm going to go in and share now.
Yeah.
Yes.
Lovely. It's showing me so many things. I'm wondering what I'm sharing. All right. So that's seen. Are you able to see?
Yes, ma'am.
Yes. Yeah. Got that.
I'm just going to put it down now. I'll do stop share and I'll go down.
Sure.
Is that okay?
Yes, ma'am.
All right.
So we have 4 more minutes to start.
Yeah.
Vaishali, is this the first of? Vaishali and Arun, is this the first of many seminars or webinars, or
So
Yes.
this
you
is
had
the
a
fifth
regular
one.
series?
Fifth.
Fifth. Okay. Okay.
Yeah.
Actually, we have a series doing every 2 weeks a webinar and basically
Okay.
focusing on some issue in breast cancer. So we had the
Okay.
first one on papillary tumors, then we had one on regional nodal irradiation, then we have had 2 on oncoplastic surgeries.
Okay.
This one is on one aspect of axillary management. Next one again after 2 weeks is on perforator flaps.
Okay.
And then we'll have a couple more on management of the axilla, other aspects of the axillary management.
Good. Good.
So the objective is every 2 weeks, is Friday or Saturday, depending upon if there are any competing events or not, and the availability of faculty.
Okay.
As I see, generally we are busy every couple of weeks.
Yeah. I know.
Hi, Pragya, how are you?
Hi, ma'am. I'm good. How are you? Thank you.
Good, all good.
Looking forward to your talk now.
We've got a whole lineup. I'm going to do the start and a little bit only we'll talk about. Detailed discussion after in the last 40 minutes, I guess.
Yeah.
Arun ensures that everybody does their bit and then comes out and they're open for a fight.
Yeah.
But I
So
guess
we have one of the panelists, Dr. Veda. Dr. Veda.
Hi.
Hi, welcome.
Hi, Veda. Hi.
No, sir.
Dr. Pranya has been attending all of our events. I have seen her regularly. So
Learning a lot, sir. Learning a lot
it's
from the
our
webinars.
pleasure always. I think we have, we try to get the best of faculties and get some interesting topics. So let's hope we continue with this.
Well, we are thoroughly enjoying it, sir. Dr. Vaishali keeps updating us about every single webinar, and so
Yeah, I
we're
know.
there. So it's been
Sure.
pretty great for us.
Thanks, Pradnya.
what's been the usual participant numbers? I see there are about 21 on right now.
So generally
In-
it reaches around 90 to 100.
Good.
At least
And
in
there are
all
a
4
couple-
events, we have had around 100 or so, and maybe 15, 20 people on the YouTube
Okay.
live stream.
Yeah. So that's a good thing to get it onto the YouTube as well. Yeah.
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 So on YouTube, then it is permanently available, and we have seen a lot of viewership after the event. So maybe 50 to 100 people watch it
Timing
later
wise,
on also.
able to adjust. Hi, Sinu.
Hi, Vani, you're looking younger by the day. Yeah.
I am.
Yeah.
So there's something called as, your retrograde. That is, you
No.
just grow younger.
In fact, I always just
There is a secret
there was
behind.
some discussion. I told
There is a secret behind.
lady who is unity in diversity, Telugu speaking, brought up in Delhi, settled in Maharashtra, married to a Gujarati.
Yes, absolutely. No, there is a secret behind how do you keep this. You have to have proactive interests like me.
Yeah.
Get
So
down
what?
to doing, actual adrenal pumping job, offroading and rallies. And then you'll see that you'll never grow old. That's the secret.
Yeah. Hi, Dylan.
Hi, Sino. I don't know if you remember me. We met in San Antonio many years ago.
Yeah. We met in
Yeah.
San Antonio and we also met in the first Sentinel Node Congress in Yokohama, I think.
That's right. That's right. Yeah.
That's it.
And you and Sumit are good friends, isn't it? Sumit
Oh,
Goyal?
yeah. Sumit is close to Arun also.
Yes.
Yeah,
I see.
Sumit
Okay.
was just one batch junior to me. I joined AIMS in 81. He was in 82.
All right. Okay. Yeah. Sumit and I are very good friends. We were registrars together in Cardiff. We worked with Prof.
Oh,
Manson.
wonderful, wonderful.
Helped set up the Almanac trial many years ago. Yeah.
Yeah, I know. So Sumit, Amit, all of these guys we keep regularly meeting and all.
Yeah. Right. Okay. Yeah.
And in fact, there are many of our friends, but a lot of them are in GI and other things from AIMS. A lot of people are there.
Yeah. No. It's
I don't know. There's one guy called Dinesh Sharma who keeps writing in Lancet small notes about Indian oncology scene and all.
I see. Based in the UK?
Yeah,
he's
based in
Kings.
UK.
He's in Kings.
All right. Okay. Yeah.
You may be knowing Kislaya. Kislaya Thakur, you might be knowing. No?
Yeah, I know Kishle very well. Yeah.
Good friend of Sir.
Excuse me, Dr. Goyal, I think it's 6 already, and we have a good number of participants already who have logged in. So I think we should start. Yeah.
So we'll start. Very good evening to all of you, all the faculty. We have Dr. Vani, Dr. Clark, Dr. Sinu, Dr. Veda is here. Maybe Dr. Selvi I still don't see, and Dr. Tushar, and all the viewers who are there. Before I start, a little bit of a sad news, which I thought we would share. Dr. Kopikar actually lost his father today to corona. In spite of that, he says he probably would log in and give his presentation. So let's see if he logs in, then we would have his presentation, but that was, we came to know in the evening only. Now coming to the event, as I mentioned in previous versions also, focus studies in breast cancer, we try to take one issue and go into the details of it so that we can have a good discussion. It can be a learning exercise for all of us also. So with that event, and you can say that I started with an agenda. The event today has been planned on surgical staging of the axilla. We generally tend to equate it with sentinel lymph node biopsy, but I am avoiding using that term because we have to accommodate other options also. What I personally feel is that a lot of surgeons, breast surgeons and oncosurgeons in many centers are hesitating to use surgical staging of the axilla and continue to use axillary dissection because there is non-availability of a nuclear medicine facility. That is, I believe, a barrier which we need to overcome. And a country like India, and there'll be many such developing countries where we don't expect that every center doing breast surgery will have that facility. So in such a scenario, how we can pass on the benefit of de-escalation of axillary management in a CN0 axilla is the objective of today's event. So the agenda which was planned is to sort of bring out various options in addition to the standard technique of the dual tracer, which Dr. Clark will talk about. Then we have 3 more faculty talking about the 3 alternates. And then I've kept about 40 minutes for a panel discussion to maybe debate the pros and cons of different approaches, the morality and ethics of using those approaches without a radio tracer and all. So from here on, I'll hand over to Dr. Vaishali to conduct the proceedings. Thank you.
Yeah. Good afternoon and good evening to all the participants, and a very warm welcome to the faculty members. We have 4 eminent speakers today with us who actually don't need any introduction, but still I would do that bit. Dr. Vani Parmar is going to go first. She is the professor of surgical oncology at Tata Memorial Hospital, Mumbai. Then we have Dr. V. Sinu, who is the professor and head of the unit of surgery at All India Institute of Medical Sciences. We have Dr. Dylan Clark, who has graciously accepted our request to present dual tracer technique in sentinel node biopsy. He is a consultant breast surgeon and reconstructive surgeon at Warwick, UK. He has also been one of the principal investigators at Almanac trial along with Professor Bob Mansell. And we have Dr. Kopikar, who is an oncoplastic breast surgeon and the founder of Orchid Breast Healthcare Center at Pune. So I would invite Dr. Vani Parmar to go first. She's going to talk about low axillary sampling as independent modality of staging axilla. Dr. Vani, over to you. Thank you so much for accepting our invitation.
Thank you very much. Thank you, Vaishali, for having invited me, and Arun for having me on board this discussion. Axilla has been one hot topic for quite some time. I'll just share my slides. Well, it says my screen is paused for any reason. Can we have that?
Ma'am, actually you stop and then do it again.
All right. It's still not happening. I'll just stop share and start again.
Yeah, I think that would work.
Yes, it worked. Brilliant. All right. So again, it says my screen sharing is paused. Can you see me or it's still not seen?
No, we can only see a text message.
I can see my screen here, but it's resume share. Does that work?
Not yet.
Okay, seems to be some issue here.
I think it has to be something to do with your probably bandwidth.
No, I don't think it should be. Maybe just try once more, stop screen sharing and.
Okay, I did a stop share. Says share screen.
Because it was working previously.
Yes.
Yes, we got it now.
Yeah, but it's
you can see.
I just want to move back. It just doesn't seem to be responding to.
No, you have to go to the screen slideshow menu probably. And
I know, but it should move back, no, to my first slide at least. Doesn't seem to be doing.
Slideshow करके देख लो.
Slideshow ही try कर रही हूँ. हाँ, अभी गया.
अब आ गया.
For some reason, it just refused to behave. It did very well when we did the trial. All right. So yeah. My topic for the day was to bring in a little, introduce the low axillary sampling, which is actually a very much Indian methodology that we had initiated way back, and it's been now more than a decade that we've been testing and have even published on the same. So a little brief, very brief on the background as to why did we think of this and where did it really start. We had evidence very clearly with us, which, one second, I just put this down. All right, so we had evidence from a meta-analysis which had clearly shown that there was a false negative rate of around 8.4% whenever there was a dual technique being used for identifying a sentinel node. And sentinel node is something that I'm not going to get into details as to why and what, but essentially it did come out that using a dual technology was far superior to using any of the technologies alone. And at the same time, there was a false negative rate, which was definitely above 5%, but below 10, which was possible. And these were multiple small studies with 8,000 patients. And and this came up in 2006. In 1999, the NSABP V32 had started, which had finished accrual by 2004 and published the data with a long follow-up in 2013. So the first publication that came out did show that sentinel node was possible with a false negative rate, again, less than 10%, 9.8, and less than 10% became a gold standard for, allowing for such kind of identification method for axilla. The 10-year overall survival data that came up in 2013 did show there was an equivalence whether or not you do an axillary clearance based upon the sentinel node result being positive or negative. So if it's negative, we don't do a clearance and leave behind 1 in 10 of patients' disease would be left behind, and that would not impact on outcome. Hence, the standard guidelines that came up accepted sentinel node biopsy as a standard of care for early breast cancer, which was node negative to begin with. Also, there was a slight modification that happened after all these when ASCO made it a point that not just the targeted lymph node, but also the palpable lymph node adjacent to the targeted node would also be considered as a sentinel node. And that's how we had the definition for sentinel node changing over a period of time. The main concerns that we've had is in non-availability of radioactive colloid and the access to nuclear medicine centers. And that was clearly brought out by Dr. Arun just now. In fact, this was research that I had done when we started the trial. We were 157 centers in India in 2004. And now in 2018, when you do a research again on how many centers are available, there are 293 in this huge country across board. And that really is not sufficient to cater for the amount of centers that do sentinel node biopsy or would see patients eligible for sentinel node biopsy. Amongst all of these, there were two studies that I'll just refer to very briefly. And this was the UK 4-node sampling study by Nottingham, where they published in the early 2000s, comparing sentinel node false negative rate with 4-node sampling, and had reported a 0.5% false negative rate of sentinel node as compared of 4 nodes as compared to sentinel node. Now, that was considered as most acceptable. So one could do a 4-node sampling instead of doing a sentinel node, which was not guided by any kind of targeted agent. A 5-node sampling was reported by Sweden around the same time, around 2005. They did not report any false negative rate, but that was another alternative that was suggested. Now, based on all this, I'm just going to give a comparative onto what do we really mean by a sampling. So sentinel node can be targeted either with a blue node or blue dye or using radioactive colloid. And the draining lymphatics pick up the first echelon lymph node. The blue stained node or the hot node picked up by either of these methodologies, along with the palpable nodes defined as per ASCO, is the sentinel node. And the low axillary sampling actually looks at level 1 lymph nodes below intercostobrachial, and it encompasses these lymph nodes as well. So the methods that were obviously being used was the dual technology of radio-guided sentinel node biopsy along with the blue dye. Of course, there are various other methodologies which I will not touch upon because I'm sure there are other speakers who talk about it, including the CNR magnetic particles, which are being used, basically started in UK. And of course, the guided low axillary sampling that I would be talking about. So in 2004 of March is when we banked upon starting this trial, which was registered. And this actually looked at comparison of radio-guided sentinel node biopsy and blue dye being used versus low axillary sampling. And these were done within the same patient. Now, the inclusion criteria was to look at early breast cancer, clinically node negative, less than or equal to 3 centimeter invasive cancer, no prior excision biopsy, or a node biopsy being done, and no neoadjuvant chemotherapy. That means these were cases that had no intervention done previously. A core biopsy of the primary was allowed. And what it required, I'm going to go a little in details in the steps. So the anatomical incision was used, the axillary incision was used, which is actually a middle third of the whole axillary incision that we use for a clearance. So it was just a 3 to 4 centimeter incision, and the dissection was limited and defined by certain boundaries. So this was to limit anteriorly by the undersurface of pec major, posteriorly by the latissimus dorsi, medially by the second digitation of serratus anterior, and superiorly by the intercostobrachial nerve. This is the first intercostobrachial, and inferiorly to include the axillary tail. And that's how diagrammatically I have shown you the area of fat and lymph nodes and lymphatics in that area were all dissected out using a blue node targeting as well. So it was a blue dye guided axillary sampling. So this is how it would be with the blue dye injected. Of course, the colloid would have been injected either in the morning of the surgery or on the previous evening. The incision length is exactly as is shown. Now, the next few slides would show it slightly bigger because to get the clear photographs of all the landmarks, it was better that we take the full axillary incision, since this was a study which had validated and we were doing completion of axillary clearance in all of them. Hence, the incision now is a complete axillary clearance incision. So the medial border of the dissection as defined was identified, blue lymphatics leading to the blue node was identified, and then the dissection would actually identify the first intercostobrachial and all the fat and lymphatics and lymph nodes below that, limited by the boundaries as defined, were all dissected out and taken out in one piece. As you can see, the upper part that is in this area, we don't actually open the fat or the lymph nodes in this area. The vein is not even visualized, and therefore the arm lymph nodes, which are mostly situated in this fat, are never touched. And this is how the axillary sampling is to be completed, with all the landmarks and clearly defined. The sampling of these lymph nodes, the actual blue node and the hot node was identified by the surgeon, labeled and sent to the pathologist in frozen section. And the processing of these lymph nodes was by standard ASCO-CAP guidelines. I'm not getting into the details of these. The results of this trial was actually published in the breast in 2013, where the comparison of sentinel node with the rest of the and the low axillary sampling was carried out, validated with completion of axilla. Now, as you can see the data here, if you look at only the targeted node, we had a 29% false negative rate, and the palpable nodes reduced it to 12.7%. But axillary sampling had a 10.5% false negative rate. The confidence intervals were actually overlapping, and there was no difference between the two. So the substitution of a targeted sentinel node using radiocolloid could easily be done by doing blue dye guided axillary sampling, or even a plain simple axillary sampling, because we were not following the blue node or blue dye. We were actually going ahead with following the anatomical boundaries and removing these fat and lymph nodes. In fact, all of these lymph nodes were found within the sampling area, and hence we actually started practicing axillary sampling after the publication of this paper in 2013. So there's a basic difference if you want to understand the applicability of sentinel node. In the West, we had smaller tumors, median tumor size being 1.2 centimeters, mostly ER positive, low grade, with an older age patient. Whereas, if you see the pathological node negativity in a clinical node negative patient, it was 85%. This is all based upon the NSFBP-B32 data. Now, India, no screening is available. The median tumor size in these patients was 3 centimeters. ER positive is about 55%. In fact, now it's about 65%. Higher grade tumors, majority being grade 3, TNBC being 30%, and the node negative patients in the clinical node negatives were 65%, the remaining with node positive. So once we started adapting this methodology, we went ahead and did an audit, and I must thank Dr. Neeta Nair for having given me these, shared this data, because this was compiled together and presented by our students in various conferences. This was the actual practice of low axillary sampling now out of trial, with frozen section being done. And the reason why this was being done is to also kind of audit yourself on your methodology of frozen section. Remember that the whole of this, any methodology, whether you do a low axillary sampling, a sentinel node, or you have any other method of identifying the positive node in the axilla, you need to have a very good frozen section facility available. So an audit was done to actually look at our own practices and whether or not what is the false negative rate, a frozen section, because your whole decision is based on this, unless you counsel every patient saying that if you have a final report coming positive, you will have a completion clearance. I'm not getting into the discussion of what should you do with 1 to 2 positive lymph nodes. That's later on. So as you can see, this audit that we carried out had 623 patients, and this was patients operated between 2012 to 2018, clinically N0 or even an N1 with a soft or suspicious node and operable breast cancer. All post-chemotherapies were excluded here. And when done, we found that there was a very high 52% positive axilla. Mind you, I had told you it was 35% in the previous trial that we had carried out, because there the inclusion was very strict. We had not taken any of the CN1s. Here we were looking at CN0s as well as N1s, with soft or suspicious node also being included in clinical practice. And if you see, the frozen section false negative rate was 5.6%. I'm not looking at validation here, because by this time we were already applying the practice of not doing a completion axilla if the node was negative. The false negative rate, as I've said, was about 5.6%. In these patients where there was a false negative rate, we already had a median of 5 nodes dissected, which was what we had shortlisted in our previous trial, that at least 4 nodes. So here there was a median of 5 nodes dissected, and a median of 1 node was found positive. Interestingly, many of these were micrometastases, which came in as later on being picked up in the final report. So micrometastasis, of course, does not make much of a difference, and we don't have to complete the axilla in these patients, but the macrometastases were very few in there. The same thing, moving on to the next step, positive axilla. You know, Z11 also came up this time. Not my audio is on, yeah. So the ACOSOC Z11 had come up by this time, and there was a huge debate on whether or not you should do the axilla or not in a node 1 to N1, if you had 1 or 2 lymph nodes positive on sentinel node. And now I'm translating this onto, since our methodology was sampling, should you have then taken 1 to 2 nodes positive in sampling and not do an axilla, completion axilla? So in this audit that we did, this is again patients who had undergone the same low axillary sampling, early breast cancer, and CN0. This was 2,350 patients in this particular audit that we carried out, more vigilant. We found out that 29% had positive lymph nodes. Now, as you can see, when you restrict yourself to CN0s and don't take the N1s, your node positivity came down to 30%, which is what was there in our trial as well. And interestingly, 86% of patients had 1 to 2 lymph nodes only positive, even on low axillary sampling. When the odds of having axilla positivity, remaining axilla positivity was checked, it was found that 3 lymph nodes, when patients had 3 lymph nodes positive, it was 1.8 times higher as compared to those who had 1 to 2 lymph nodes. So obviously 1 to 2 looks to be a similar kind of population as the ACOSOC Z11. But patients with anybody who had more than 4 had a very high, 6 times significantly more likely to have an axilla positive. So there was also a 48% probability of an additional node being positive with every increase in the low axillary sampling node positive. And 2 important factors that were impacting were perinodal invasion and lymphovascular emboli. The presence of these 2 have always had a negative impact on the outcome. But what is more interesting is this comparison, which I really liked, which was the current cohort being compared to the ACOSOC Z11 comparison. Now the numbers that you see, 597 in the current cohort compared to 420 in the ACOSOC Z11 arm. What is striking over here, a few things, is one, our grade of tumor was definitely much, much higher. We had 73% grade 3 tumors as compared to 22% in the lymph node dissection arm, and in the sentinel node only arm, 20%. So obviously we had a very much higher grade tumors. LVI positivity was also much higher. In fact, it was double those who were the sentinel node alone versus those who had dissection also. And the hormone receptor positivity, though similar, see, it's much different now. It's 77% as compared to what we had said earlier of 55%. But interestingly, micrometastatic disease was way lower as compared to what we were seeing in the West. And that's exactly where the difference comes in, because micrometastatic disease is much, much lower in our data, and a higher grade tumor with LVI positive and a micrometastatic disease all put together gives out a data which is indicating patients with a poor outcome, and hence an ACOSOC Z11 outcome may not be applicable to our patients. And this is what was concluded from this comparative analysis. Of course, validated nomograms can be used to identify the high-risk patients. We know that tumor size does have an impact on the positive lymph node status, and as the lymph nodes tumor size increases, the lymph node positivity increases, and this is seen both in early as well as post chemotherapy status. And more the number of lymph nodes, higher the number of nodes involved. Again, the two important things that stand out here also is number of nodes, perinodal extension, and lymphovascular emboli. The same three factors that came up in the earlier analysis also comes up in this. The same low axillary sampling was then tested in a set of patients who had received neoadjuvant chemotherapy. Since in early breast cancer, it had already become standard of care for us, we moved on. And in fact, many centers outside of the Tata Memorial Center are also accepted this as a normal procedure. We moved on to the post-chemotherapy situation. We do know that the HER2 positive and triple negative are higher in our population, and also that they respond much better. So doing the sentinel node biopsy in these patients receiving chemotherapy, where we know that when it is done before administering starting chemotherapy, it would not be good because you would probably tamper the axilla one. Secondly, you might label a patient as node positive when no node was palpable, and then end up doing a clearance in spite of having a brilliant response to chemotherapy. So we do know now with all standard, with the results available, that it's better to do the sentinel node biopsy after chemotherapy in these patients who have received chemo. And quite a few patients become actually YBN0 from an N1 status, and then they can be spared axillary surgery as well. That was the hypothesis on the basis of which day priori that we started off on checking whether or not we can apply the same procedure and how does it compare to a dual technique as well. Now we know that there was enough data to say the false negative rate is always high post neoadjuvant chemotherapy in a patient who has turned node negative after chemo. And this was cleared by the meta-analysis as well, as we had the previous meta-analysis in early breast cancer. Zinc meta-analysis was there in the post-neoadjuvant status of larger tumors who've received chemo. The false negative rate reported here was 12 to 33% after chemo. The ACOSOG Z1071 or the Alliance trial had clearly shown us that the false negative rate with fewer number of lymph nodes being picked up was always higher, and it came down as number of nodes were picked up during sentinel node biopsy was lower. So we had data to say that more the number of lymph nodes, lower is the false negative rate. But even with 2 nodes, it was 12.6. So when pre-neoadjuvant chemotherapy, all are node positive. The other trials that came up and reported, and all had a high false negative rate above 10%. And if you take the same criteria, the 10% is the acceptable limit, we already had data to say that every trial that was being reported had a high false negative rate. But at the same time, the SNFNAC also said that, if you had more than 3 lymph nodes identified, whether by dual tracer or whatever, the false negative rate seemed to fall below 10%. In fact, it was 4% in the FNAC trial. So interestingly, we had now evidence to say that more the number of lymph nodes, even in the post-chemo situation, we may be able to actually predict the axilla better. A more recent meta-analysis in the same N1 pre-neoadjuvant chemotherapy turned N0 after chemotherapy. We had an updated meta-analysis reported in 2016. Again, 19 articles reviewed. Again, false negative rate 13%. You can see that everywhere it's about 10%. So going by that, we did a study in which we did the same post-neoadjuvant chemotherapy, low axillary sampling. This has been completed. This data has been analyzed and it has been presented at San Antonio 2018, as well as the manuscript is now accepted by the JCO for publication, JCO Global Oncology, in September. That's this month. 751 patients, the identification rate, as you can see, was very good with low axillary sampling, 98%, as compared to a sentinel node targeted alone of 85%, and with palpable being 95%. The FNR, now I'm going to take only the gold standard that ASCO has said, that along with palpable nodes, the sentinel nodes along with palpable nodes had a 19.7% false negative rate as compared to low axillary sampling, where it was 9.9%. The minute we brought 3 or more lymph nodes in low axillary sampling being picked up, the false negative rate was brought down to below 8.8%. So as you can see, this did not happen with sentinel nodes. When only targeted node was identified, the false negative rate was very high. It was 31%, which did not reduce even when we picked up 3 or more lymph nodes. I'm not taking the palpable here because we're looking at sentinel node with number of nodes being picked up, where it included even the palpable. So it did not reduce even when 3 or more lymph nodes were picked up. So there seems to be some issue when we are using targeted technology or targeted methodology in a post-neoadjuvant status. So as far as long-term outcome, we know that to adapt this now as a standard of care in post-neoadjuvant chemotherapy, large tumors after chemotherapy, we will probably have to wait for outcome data, which is being collected now. The only data that's been published is by Viviana Galimberti in the European Journal of Surgical Oncology in 2016. Very small subset of 396 patients, and who are all a mix of node negative and node positive before chemotherapy. And as you can see in the median follow-up of 61 months, that's 5 years, the outcome seems to be definitely acceptable. But the problem here is it's a small sample size, it's a retrospective data, and we'll probably have to wait for our own data to build up, because we have different biology of tumors that we see here, different grade of tumors, much worse. So I think I leave you with this thought that we do have an alternate technology to be used in Indian patients, especially in the early breast cancer. Low X-ray sampling has proven itself to be a very reliable technology, as reliable as the sentinel node that has been used by the dual methodology. As far as the lymphedema rate, in fact, we have early data now to say that the lymphedema, the difference between when sentinel node is done or when you're doing a sampling, the difference is only at 3% versus 6%. It's just too small to now to analyze on lymphedema rates. As far as paresthesias are concerned, there is no paresthesia. Using of the arm can be used because we don't go beyond the intercostal brachial. We don't touch the arm lymph nodes. In fact, there is a reverse mapping study as well that is started now, which is looking at how often do we get the arm lymph node actually in the sampling specimen. Those data are still awaited, but currently, as I see, I think that's the last of my slides, and we are ready to even adopt this even in the larger tumors who receive neoadjuvant chemotherapy.
Yeah. Thank you, Dr. Vani. You have set the tone of this meeting perfectly. Actually, I would like to share with you great news that it's Dr. Vani's birthday again as well today. So on behalf of all the participants, we all wish Dr. Vani a great birthday. Thank you so much for joining us today on your birthday.
Thank you.
Yeah, thank you. We are actually going to have a panel discussion, and I would request you to please be with us because you're going to be one of the panelists. And we'll take the questions in the panel as well as towards the end of the session. So thank you, Dr. Vani, once again. This slide, Dr. Sinu, Dr. Kopikar actually wants to go ahead of you. So if you don't mind, because is that okay, Dr. Sinu?
Yeah, absolutely fine.
Yeah. So, Dr. Kopikar?
Yeah. Okay. Yeah, I'm here.
Yeah. So, if you could start sharing.
Yes. Yeah. So.
Yeah, we can see now. Yeah.
I think let me start off immediately. And thank you for inviting me today. And I'm sorry to request a change in the timing. However, thank you again for that. Changing concepts. There are changing concepts in management of axillary management. And there have been 3 eras that you really can make out. One was the era 1 where whatever the nodal status, there was always an axillary dissection. There was an era 2 where upfront SLNB plus, which was positive, had had an ALND, whereas negative, there was no further treatment. Now era 3 is where clinically node negative or node positive axilla post NACT, if there is a good response and you have a normal axilla, either a normal axilla imaging post NACT, then you do an SLNB. If it is negative, you avoid an axillary dissection. So this is the changing era, and what is needed therefore is that the identification of sentinel nodes and reducing the false negative rate seems to be the most important aspect of doing a sentinel node biopsy today. And as very nicely pointed out by Vani, that even in her series, they have shown that getting more nodes out has been possible with their technique of lower axillary dissection. So I think more and more techniques need to be evolved where you can really identify more sentinel nodes if you are doing the sentinel node procedure. So that is the reason why you probably need to seek new techniques in sentinel node biopsy. Why seek them in the country like ours? Because radioisotope requires licensing for the institution. Its regular BRC regulates its production, transportation, and disposal. Reactors producing isotopes are aging, hence doubt remains on its supply reliability. Supply is always a little, especially in Tier 2 and Tier 3 cities. The penetration of technology is again mainly in the Tier 1 setup, and upfront capital investments are huge. Therefore, I think most of our country is now actually using only blue dye, which has a low sensitivity. The challenges with the methylene blue or the isosulfan blue are that the detection rates of methylene blue as a single tracer is less than the dual tracers that all of us know. Comparatively higher false negative rates to other established tracers. This is what has the literature shows. For isosulfan blue, reported incidence of allergic reactions are there of about 1.6%. And the staining of the site, surgical site, as well as possibility of skin necrosis with methylene blue, if injected intradermally, is very, very possible. Therefore, there are new techniques. One of them has been indocyanine green, completely bound to plasma proteins. It fluoresces in the infrared wavelength. It's injected very minimally subdermally into the periareolar region, and the fluorescence is visible in near infrared camera. Super paramagnetic, just to mention these other techniques which I have really no experience of, is the supraparamagnetic iron oxide. Seems to be very cumbersome to actually employ. The fluorescence, which seems to be the cheapest way of doing it, but is probably will lead to a large number of nodes because of the low molecular weight. The computer tomography lymphangiography, which lymphography is another method which has shown to be very effective in identifying sentinel nodes, but is still to meet the requirements of the day. Spy fluorescence modes. When we are doing a spy fluorescence, there are three modes of that you can see the lymph nodes with. One is the overlay fluorescence mode, which is the green mode. It's very useful because because you can actually dissect the nodes and also identify your normal structures in the axilla, and therefore you're guided towards the node. You can save the other tissues that you want to save while doing an axillary dissection. And I think one of the greatest advantages of spy fluorescence sentinel node dissection is that it is real time, and you can really in real time see where you're going, how do you avoid other lymphatics and the nerve, etc., which you can actually very clearly see magnified on the TV camera. It's the spy contrast mode, which is a very which identifies the lymph nodes very specifically, and the color segmented fluorescence mode, which is very useful to differentiate between the the quantity of the level of perfusion, so that in case of spillage, you may be able to identify those areas of the node which is actually the lymph node and not areas of spillage. So these are the three modes, and the demarcation of SLN without affecting other anatomy is the advantage of this. Visualization of the fluorescent skin penetration, very, very nicely done by the spy camera. So this is how you inject the dye, and the dye is injected subdermally, and you trace it out into the axilla. And as soon as you see it going into the axilla, you can take your axillary incision. The axillary incision is taken, the lymph node is identified. You can see the dye going into the lymph nodes. Try to stay away from the efferent lymphatics. Try to dissect away and bluntly, so that you do not cut the lymphatics draining into the node till the very end. You can see that we are now looking at it, and many times now, in fact, we have been reduced. We then go into the overlay mode or the green mode, so that you are able to identify where you're dissecting and really take out only the sentinel nodes. very effectively. Once this sentinel node has been removed, you look into the axilla. This is the sentinel node which is removed. Then this is the green mode, and then that is the overlay mode, where you can see very clearly the quantity of perfusion in this area as compared to the other. So this is where your lymph node and the maximum concentration of the dye is. So this is the quantitative way of measuring this. And then you look into the axilla and see if there are any more lymph nodes, and you put into this mode where you can see that there is no red areas in the axilla. So yeah, we are sure that there is no more sentinel node evident over there. So the novel technique for sentinel node biopsy in breast cancer, a systematic review was done by Purushottam and co-workers and presented in Lancet Oncology, in which they concluded that ICG was significantly better than blue dye in the terms of improved sentinel node identification in the fixed effects model. In the random effects model, there was no statistically significant difference between ICG and the radiocolloid. Comparison, there's another comparison with a single center randomized study by Yon, where he showed that the difference between technetium and between iodosin green in conjunction with radioisotope is equivalent to, is in fact slightly better, is more sensitive than in the isotope and blue dye. So there was a meta-analysis also where they showed that the ICG fluorescence technique performs well for sentinel lymph node detection and shows a trend towards better axillary staging compared to the radioisotope. But these are just trends. There is no randomized data at all. So really, there is still more data awaited. And there was this one study, which was again a pooled analysis estimation of detection rates and false negative rates done by Mock et al. From Singapore, and where he suggested and showed that the detection rate was the most best with the ICG, and where the blue dye, when they compared all the techniques, the blue dye was really the most least sensitive of the various methods. Therefore, axillary management post neoadjuvant chemotherapy, as has been alluded to by Dr. Vani, is that NAC downstages axilla in more than 40% of patients, potential to consider SLNB after NAC, to avoid ALND, and should management depend on pre-treatment clinical stage, clinical node negative, clinical node positive. So there is a lot of controversy. And basically most of the centers abroad, and as Vani pointed out, that they really see smaller tumors. And it showed here that when chemotherapy was given first, without any difference in the locoregional recurrence, the dissection, the ALND rate was lower when chemotherapy was given first. And also, she alluded to the fact that more than three nodes identification led to reduction in the false negative rate. So that is where we need to be headed. And we know that ICG, due to its lower molecular weight, diffuses into disturbed lymphatics better than radiocolloid. In a de novo situation, ICG is known to identify more lymph nodes than the radiocolloid. In fact, that is one of the objections to ICG, but in the post-NACT setting, it's probably an advantage. So a combination of ICG and blue dye may be a good option in the post-NACT sentinel node detection because of the increased detection of more sentinel nodes. Sentinel node detection, there was this paper from Japan where he assessed the effects of NACT on lymphatic pathways, and he concluded that SLNs can be safely performed with ICG mapping, but of course this was a very small study, and he showed that the SLN detection 100% in the clinically node negative versus 93% in the clinically node positive with ICG lymph node mapping. SLNs detected in the same location before or after NACT. Lymphatic pathways detected without influence of NACT is what he concluded. and the location of the lymph nodes were the same according to this paper. The sentinel node biopsy using ICG compared with radioisotope only method for breast cancer post-neoadjuvant chemotherapy. This study again demonstrated that SLNB using dual method using ICG was comparable with the conventional radioisotope method. So therefore, wherever it is, where it can be implemented and can be used, especially in institutions that do not have nuclear medicine facility within their institution, to employ the radioisotope, I think ICG is an excellent mode of doing an SLNB dissection. Great advantage lies in oncoplastic surgery, that you kill two birds with the same stone, fluorescent aided vascularity assessments along with mapping. Oncoplastic approaches dissect lymph node many times through the same incision, especially in therapeutic myoplasty and perforator flaps. Oncoplastic incisions may disrupt the fluorescent channels, and that's why we probably
there are basically 7 steps which are involved in providing the safety steps, or the hurdles which require a safe approach to ensure good outcomes in our patients. And I'll be dealing with each.
Hello.
Yeah, please go ahead.
Yeah, therefore, with oncoplastic surgery, we probably need to design the incisions well, when probably find some method of trying to not cause spillage when we are doing the dissection. And that is one of the challenges of oncoplastic surgery. For example, if we were to inject the dye here, right here at the nipple areolar complex lateral to it, then you would actually be cutting into this thing, into the pathway of the dye, and cause a lot of spillage. And therefore, probably we need to dissect here, go into the axilla and get to the lymph node. So this is one thought that we have been having since we have been including this with our oncoplastic surgery. So this is a patient where we are doing a therapeutic myoplasty, and you can see because the incisions are going to lie there, we are injecting the dye first, and then we are actually forced to take an axillary dissection, axillary incision. And just to show you the technique again, we find the node with the SPY technique and dissect the node carefully without disrupting the lymphatics, and then you put it into the other modes to recheck to see that the lymph nodes are completely dissected. In this patient, we found 2 nodes which we dissected out, and then at the end of the procedure, you look at from the segmental mode and see that there is no more axillary dissection. I'm sorry, this slide should not have been there. I've been a little, I'm sorry for that. So even with the sentinel node, when we are doing with the perforator flap, it is usually the injection done there, the perforator flap mapped out, and then through this incision here, you go in and identify the node first, then dissect the lymph node. I mean, dissect the tumor. Whereas most of the authors abroad have said you usually do an axillary, you do the axillary dissection last, and you do the tumorectomy first. However, we need to change the plan here if you are to go in through this incision and use the ICG. So basically, that is a different approach to the surgery. Again, in the same thing in this patient, we have approached the lymph node through the upper limb of the incision for the flap. Now, just to show you that in this patient where we first do the sentinel node mapping, the injection is done there, the map is done, and through this incision, you would go in and do the upper end of the incision, you would go and do the axillary dissection. And then you would go ahead and do the lumpectomy, and then go ahead and do the flap insertion into the lumpectomy cavity. And that is a LTAP flap that is being raised. And actually, just before inserting it, unfortunately, I didn't have it in this video, but in the next video, we'll see that you can actually also do the vascularity assessment. So this is a flap that we are taking, LTAP flap again, and you can see that after we have dissected the flap, we are now going to see the vascularity of the thing by putting on the SPY mode and look at the whole flap to see that the vascularity is good. You can see that the tip is slightly underperfused, so we can take out that part of the flap, and then therefore it's a sort of a double whammy for us. So when we do these flaps, you can actually see the perforators going into the flap also very, and so you see this is a well perfused flap after surgery. And basically that you can see the vascularity also by after when we deepitalize it, that the vascularity is good. So basically it's just an added advantage. In our experience with our upfront surgery, we have analyzed our 239 patients. Our false negative rate is around 7.3%. Post NSCT, our false negative rate happens to be only 3.9%, but our numbers are very small, just 53. And with the ICG, and in some cases dual technique, but nowadays mainly only ICG. We have done about 66 cases, and our false negative rate is around 8.3%. Now post NSCT, we had only 9 cases up to now, so we have not been really able to assess anything with the ICG. But whatever our little experience, we can see that we are really able to identify more and more nodes, at least 3 to 4 nodes, when we do a central node with the ICG, and our identification rate is nearly 100%. Now, this is one of the advantages of molecular imaging, photoacoustic spectroscopic molecular imaging that might come out as an advantage of ICG contrast agents. And now we are getting specific contrast agents like the B7H3 targeted ICG contrast agents for actually delineating between a cancerous region and a benign lump. So basically, that's one of the futures of ICG imaging. And the prospects from India, there was this article written by Dr. Goel and Vaishali Jambre, where they suggested that there's a major problem in India for the access for sentinel node biopsy. And they suggested that alternative options like the ICG was probably better. How does fluorescence angiography work? And I think this is probably not a part of our talk today, so I think we'll omit that for time. Vaishali, is the time over? I'm sorry, I had not raised that. Hello, Vaishali.
Yes, sir. In case if you have something more to share, you can take maybe a minute or 2 more.
Okay, just to show you that really the complication rates, necrosis rate, and the direct to implant procedures have increased because where surgeons have started using the SPY camera, and the overall complication rates of intraoperative SPY because of skin complications have also drastically dropped. And therefore, you can see this is just I'm just showing one last video of how you can really see this whole thing light up so beautifully with the ICG fluorescence imaging. And you can see the perforator coming in there, supplying the whole tissue, and you can see the whole flap getting well perfused. So with this sort of thing, when you are doing even LD flap reconstructions, I'm not going to show the whole video, but we had to actually excise a little part of this flap so that to avoid skin necrosis. So this is how we found that this area was not well perfused, and hence avoided any complications in this patient. So I think with that, I would like to just thank my team and all those who have helped me through making these presentations, especially my team at the City Orchids and CTCR, Dr. Santosh Dikshit, Upendra Dhar, Inu Varghese, and Madhura, Devki, Smita sister, and Dr. Nutan. And I think with that, I will end my talk today. Thank you so much.
Yeah, thank you, Dr. Kopikar. We all actually appreciate that despite your loss, you've taken pains to honor your commitment. I'm sure you have to leave, but before you leave, can you take one question?
Sure.
So Dr. Neha actually wants to know whether if the patient has undergone previous lumpectomy, would the site of injection for ICG change? Or can you do it in case if the patient has previously undergone lumpectomy, can you use ICG successfully for sentinel node biopsy?
Yes, so it can be done. And we, in 2 situations, we tend to give sometimes an additional small 0.05 ml of ICG dye. Hello. So,
Dr. Suvarna, please mute yourself. Yeah.
So basically we have, I'm sorry, I lost the link there. So yes, what we do is inject normally, just like you would do otherwise. And if the incision is in the lateral quadrant, you can inject 0.05 ml of dye, again, just lateral to that in the skin. But I can tell you, with the little experience that we have, ICG seems to be able to circumvent incisions and post NACT fibrosis and still diffuse into the axilla. This is something that we are seeing, but I would suggest that if there is an incision especially in the outer quadrant, you can inject a very small quantity outside also. The other place where we tend to inject a little bit away from the areolar nowadays is when we are doing therapeutic mammoplasty, because we would like to inject just outside the outer incision so that we do not spill the dye and cut into the efferent lymphatics. And we are able to track, as I showed you in that slide, through the lower, and because of paucity of time, I have not shown you all those videos, but through the lower quadrant incision, you go into the axilla and dissect the node from there. So that's another situation where we are looking at injecting the dye slightly lateral to the and not at the skin areolar junction.
Yeah. I'm sure, Dr. Neha, that has answered your question. Thank you, Dr. Kopikar, once again. Now I think we would move on to Dr. Sinu. Dr. Sinu is going to take us through sentinel node biopsy using blue dye alone. Over to you, Dr. Sinu.
Hi. Are you seeing my screen?
Yes.
Yes, sir. Yes, sir.
Okay. At the outset, I thank Arun, with whom I have been associated for more than 25 years in surgical oncology. We have seen the ups and downs of life while working in the Department of Surgery and also at IRCH. And also Vaishali, whom I have known for last almost 10 years, and I've seen her grow to become a very confident surgeon.
Thank you, sir.
The thing about which I am going to talk is about sentinel lymph node biopsy using the blue dye technique. I took the liberty of altering the title, saying that sentinel lymph node biopsy blue dye technique revisited. And I'm saying this because way back in 1998, we started doing sentinel lymph node biopsy. And our first study was, in fact, published as a thesis right in the year 2000. So this was the time this work with the first thesis led us to write a leading article in the National Medical Journal of India, saying sentinel lymph node biopsy and breast cancer, a new paradigm, along with Armando Giuliano. Now, the first study which we did, like I'm sharing the results of the first study, which was done as a thesis. The sentinel lymph node could be identified using blue dye technique alone was about 95.3%. This was done in about 64 patients with an overall concordance of about 96.7% and a false negative rate of 5.5%, which is now considered as acceptable. However, when you see the sentinel lymph node identification in patients with tumor more than 2 centimeters, the success rate was slightly higher, slightly lower as compared to those with less than 2 centimeters. So from this study, we could conclude by saying that the sentinel lymph node can be identified with a fair degree of success, even in large operable cancer, and it accurately reflects the axillary lymph node status in this patient and is not associated with any serious complications and is safe and feasible even in Indian settings. Now, let me take you through the history of sentinel lymph node concept. The sentinel lymph node concept was actually introduced by Cabanas in 1997 for penile cancer, all of us know. But the way it is being practiced today has actually been introduced to us by Don Morton while working with melanomas in John Wayne Cancer Institute. And during the same time, Armando Giuliano applied it to sentinel lymphadenectomy in breast cancer. So when I was in John Wayne, there used to be a story going around that why Don Morton took up this thought of mapping the lymphatics, because the John Wayne Cancer Institute was a referral center for melanomas for the entire USA, one of the referral centers. And he came across quite a few melanomas which occurred in and around the umbilicus, which meant that if they had to do a dissection, they had to do dissection in both groins and both axilla with considerable morbidity and sometimes mortality. So that's why Morton resorted to mapping the lymphatics, which started going from the umbilicus. So this is the story about the sentinel lymph node concept, how it has got evolved at the John Wayne Cancer Institute. Now, a lot of you are very well versed with it, and I will not go much into it, except that the sentinel node concept is based on the belief that any tumor, solid tumor anywhere in the body, drains to one or two nodes in the regional nodal basin. And if you can identify this, this should logically reflect the status of the entire regional nodal basin. And sentinel lymph node is invariably a cluster of lymph nodes and not a single lymph node anytime. Now, the techniques, you're all like for some of the postgraduates over there, the dye-directed technique, the radiotracer-directed technique, and the combination technique. And currently recommended technique is the combination technique. Now, I'll be talking about the blue dye technique. And the blue dyes which are currently used are isosulfan blue, patent blue, violet, and methylene blue. Now, when Don Martin did the study, he actually published even about the feline studies where he used, apart from isosulfan blue, patent blue, methylene blue, he also had used fluorescein. And in his study, he said that methylene blue is not a very good blue dye because the particle size is smaller, so it goes more into the blood vessels rather than the lymphatics. However, because of the paucity or the lack of availability of the isosulfan blue, even in the US, it was more by chance. It's something like a serendipity that people have started using methylene blue. Centers world over are using methylene blue. Now, the route of administration, which was being talked about just now as to following lumpectomy, can be either intraparenchymal, intradermal, subdermal, or subareolar. So depending on your convenience, you can use it. But if you are using an intradermal injection of a methylene blue, it is always preferable to excise that part of the skin because there is chance of necrosis. Now, this is one of our first patients. We injected the blue dye. This was a wire-guided localization. And this is how you can see. You can see a brilliant blue lymphatic against a fatty yellow background going to the lymph node. And this is the excised lymph node along with the lymphatic tract. And it is very important that the lymph node should always be excised with the perinodal fat, because if there is infiltration of the tumor into the surrounding perinodal fat, then it's always better to excise the tumor, at least a tumor-free fatty tissue around the lymph node. Now, the technique which I follow, like which Arun wanted me to share in this presentation, is the technique which I learned from Armando Giuliano when I was there with him about 3 months. And I'll be playing a small video of this technique. It may take a little time because unless the cursor comes, I don't think the video will play. Or shall I play the video from the, I think I'll go on to another screen.
You can try going into slideshow and then you should have the cursor should come on. If you move
it is in slideshow only. Okay, now I'm playing this video. Are you able to see the video?
No, we can see the screen, but not the video.
Okay. So let me go to Zoom.
you can try and move your presentation onto slideshow, you may be able to get a cursor onto that.
Yeah, new share. Are you seeing the video?
No,
Not yet, sir.
Not yet. Actually, just now when I...
We still have the PowerPoint screen, not the video.
Now also? Wait.
Yeah.
Share the screen again. Do I have to unshare and then share? Arun?
Stay on top, on your top browser, you've got, we're on view. And if you move to left to slideshow instead of view, can you see that on the brown? Move to slideshow.
Wait, I think I've opened too many.
Just play it from the laptop directly, the movie alone.
Yeah, but I'm there on the laptop, but I'm not getting it.
Stop sharing and then come back.
Maybe stop sharing and then reshare the.
No, I'm not getting mine.
Seenu, your...
I think I'll skip the video then.
Yeah.
Are you seeing my slides?
Yes, we can see your slides now.
Now I'll see at the end if I can present. The side effects and the complications, the allergic reactions and anaphylaxis, they have been shown only with the lymphazirin, not with the methylene blue. And decreased oxygen saturation. This used to perturb us in the initial phases, but then we realized that this is seen only on the pulse oximetry because of the interference with the oxygen saturation curve in the probe. And whereas when you do an arterial blood gas analysis, it comes out normal. Majority of the patients will have a blue colored urine for about 24 to 48 hours. And blue tattooing of the skin, again, temporarily lasts for about 1 to 2 weeks. And skin necrosis may need excision in some patients. And induration can be there at the operations at the injected site, especially in methylene blue, which resolves over a period of few months. Now, the allergic reactions and anaphylaxis, as I've told, have been reported in about 0.7 to 1.9% of patients in 5 institutions over comprising of about 4,247 patients. And these have been classified into 3 distinct grades, grade 1, 2, and 3, depending on how severe they are and whether they need a vasopressor support. However, none of the patients who had a blue dye, whether it's isosulfan blue or patent blue, no deaths were reported. Now, this is one of the studies which shows the complications with methylene blue. As you can see here, majority of the complications are only local inflammation and skin necrosis. The commonest is in the Varghese group, which is the temporary blue staining, which was seen in about 329 patients. Besides, the complications are not many and they're not very serious. Now, in our study, what we found till now is that we had skin necrosis in 1 patient in the methylene blue group, and we have blue hives in 2 patients in the patent blue violet group, and there were no major anaphylactic reactions. And now coming to the results of the sentinel lymph node biopsy using the blue dye, as you can see here, even in Giuliano's hands in the initial phase, the identification rate was just about 64.5%, and which once he gained experience became 94%, and the concordance rate also improved and the false negative rate came down drastically. So Miltenberg did a meta-analysis again in the initial learning phase of sentinel lymph node biopsy, where identification rate was about 74%, where though the identification rate was low, the concordance rate and the false negative rates were acceptable. And these are the studies, the lower studies of Noor, Varghese, and ours, the latest studies. They are all with methylene blue, which show that the success rate is more than 91% with a good concordance more than 96% and an acceptable false negative rate as per the guidelines. And this is our unpublished data. Initially, Like our false negative rate was 88.1%. And recently, because of the COVID, we had difficulty in procuring the radio tracer. So I had the opportunity to do sentinel lymph node using blue dye in about 37 patients. And it was successful in about 94.2% of the patient with 100% concordance rate and no false negative rate. So this suggests that in experienced hands, the blue dye technique is fairly good and the success rate is more than 90%. Now, what are the advantages of the blue dye technique? It is inexpensive and it is easily available. And why I'm saying it is easily available is that recently I happened to go to a place, a rural area in Andhra Pradesh called Mangalagiri. I went to buy some medication and just out of curiosity, I asked them whether methylene blue is available. And they said, yes, it is available. So methylene blue is easily available. That is the advantage of as far as our country is concerned. And for a surgeon, it is very easy to identify blue stained lymphatics against fatty yellow background. And no second echelon nodes are removed. No radioactive scatter is seen, and it can be used even for reverse axillary mapping and second echelon nodes. So this is one of our studies which recently tried to optimize sentinel lymph node biopsy for Indian settings. And in this study, as you can see here, the success rate using methylene blue versus patent blue violet was equally good. There was no significant difference in any of the things, whether it is the identification rate, number of nodes removed, and the number of positive nodes. Though it was done along with the radio tracer, the number of blue dye nodes which were recovered using methylene blue and patent blue violet were similar. And it is very cost effective because the methylene blue just costs about 15 rupees per vial. And for the purpose of this study, we imported patent blue violet, which cost us about $91 per ampule. So the cost of performing sentinel lymph node biopsy is significantly lower when methylene blue was used. Now, it is easy to identify blue lymphatics against a fatty yellow background. All of us as surgeons are very well aware of this. Like when you see in close magnification, you see brilliant blue lymphatics which go to blue nodes, and no surgeon can miss this. And no second echelon nodes removed. Why I'm saying this is that like this is one of our early patients where we used to do lymphoscintigraphy routinely. Now we don't do. This patient at 30 minutes, there was only one node which was seen. But for some reason, the patient couldn't come to operation theater. So she underwent a re-lymphoscintigraphy because those days we were not confident of sentinel node. And look here, so many nodes are seen. So if you do with a gamma probe, you tend to remove more number of nodes. Like even when you see the literature, when you see the mean sentinel nodes in the initial studies, the mean sentinel nodes were about 2.2, 2.4. Once radio tracer has been increased, it suddenly shot up to 2.8. And the average number of sentinel nodes removed vary from 1 to 4 in most studies of sentinel node, including ours. Whereas when you look at the radio tracer, it goes even up to 9 lymph nodes. So you tend to remove lesser number of nodes, which is actually the purpose of doing sentinel lymph node biopsy. Now, no radioactive scatter. Again, all of us are very well aware that in some patients, as soon as you take out the probe from the box, it starts giving beeps. So it does interfere, especially if the tumor is in the upper outer quadrant and you inject it intraparenchymal rather than subareolar, then definitely there is interference with the radioactive scatter in finding the lymph nodes, which is not the case when you use the blue dye technique. And the other thing, just now I saw one of the participants talk about reverse axillary mapping with ICG. Like it is possible to do reverse axillary mapping, and whenever you want to do reverse axillary mapping, you cannot use the same dye for the sentinel node and also for mapping the lymphatics. So which will be possible only if you use either a blue dye or probably a ICG. Whereas the other thing is, if you're interested in research and you want to know whenever the first echelon nodes is there, how many second echelon nodes you remove and see the involvement, then also it is the blue dye which helps you do this sort of research work. Now, the biggest disadvantage of sentinel lymph node biopsy is a strong learning curve. And as with any dyes, if you transect the lymphatics right early in your procedure, then the blue dye may not reach the lymph node. That's why whenever you give an incision, you give an incision just the skin and the subcutaneous tissue, then dissect gently and carefully when you identify the lymphatics. When you identify the lymphatic, you massage the breast better so that the blue dye drains into the lymphatics and they start looking much more brilliant than what it appeared before. So if lymphatics get transected right early, then probably the sentinel lymph node will not be seen with using the blue dye technique. And this is about the learning curve, which I was talking about. Like, as you can see here, this is by McMasters in 2001. Again, in the initial phase of the sentinel lymph node biopsy, as you can see here, this curve represents the sentinel node identification rate. This curve reflects the false negative rate. And once the number of cases go more than 20, the identification rate starts increasing and the false negative rate starts decreasing. So definitely there is a learning curve. The learning curve when Don Martin did for melanoma was about 40 cases, but later on through various studies, it has been found that if somebody can do more about 20 sentinel lymph nodes under supervision and then starts doing, then the identification rate will be more than 90% and the false negative rate will be less than 5%. And this is again the same study which shows that the surgeons who performed about 1 to 20 cases only, the sentinel node success rate was about 91%, false negative rate was 9%. And once more than 20 cases are performed by surgeons and when you look at their results, the sentinel node identification rate is about 96.7% and the false negative rate is less than 2%. And this is another study which is with methylene blue alone. And this you can see here, like when they talk of 100, this is not the number of cases, this is the percentage. They found that inexperienced, and all these were surgeons who were very experienced in doing sentinel lymph node biopsy. And they found that when they compared the blue dye with the combined technique, the surgeon 1, 2, 3, 4, 5. Okay. So when you look at them, like even with methylene blue, like this and the combined, the identification rate and the concordance rate, whether they perform in 30 cases, next 30 cases, 90 cases, 120 cases, 150 cases, the sentinel node identification rate and was equally good as compared to the combination technique. Now, the other disadvantage is the no commercial, pharmaceutical or industry interest. This is an extremely important thing as far as our country is concerned. All of us who are in medical profession and who have been in research for the last 20, 30 years, we very well know that for a technique to take off, especially in surgery or in medical oncology, the technique or the drug to take off, you need support of the pharmaceuticals or you need the support of the industry. If you have a support, then the technique just zooms off. Unfortunately, sentinel lymph node biopsy using methylene blue is nobody's baby. There is no commercial interest, there is no pharmaceutical interest, there is no industry interest. And even in corporate sector, I don't know how it works, but if you start doing sentinel lymph node biopsy only using blue dye, then probably there can be problems because you are not involving another department which provides service to the patient. So this is an extremely important thing why I feel the methylene blue is not taking off, whether it is in the West. In the West, they don't need it, especially in our country. And you also very well know that, like as Vani has showed, that only 293 centers in the country have radio tracer facility. So all the more it is essential that we need to propagate that methylene blue is as good as probably combination technique. Now, again, this is my favorite slide. Like when I used to talk about sentinel lymph node biopsy in 2000, 2001, I used to give 4 to 6 lectures per year. I used to say establishing a sentinel lymph node program needs validation of both surgeon, nuclear medicine physician, and the pathologist. But today I feel that probably what you need is just the surgeon and the pathologist, and these are enough to first assess the feasibility and the validity. So I conclude my talk by saying that sentinel lymph node biopsy using methylene blue is feasible, safe, and it is ideally suited for resource constrained settings like our country. especially because in India, majority of the surgeries even today are done in smaller institutions. And majority of the Indian surgeons are so good at the technique of doing axillary lymph node dissection that they can finish it in 20 minutes. So they do not get attracted to sentinel lymph node biopsy. One, because it is propagated that combination technique is the best technique, and as per guidelines, it is the only technique to be used. Yes, it is the only technique to be used if you want a sentinel node identification rate of more than 95%. Even by going all the all the available literature, like whether it is meta-analysis of 1999 or meta-analysis of 2011, methylene blue identification rates can be at least between 80 to 85%. So if we practice methylene blue, we can identify the sentinel node at least in 80%. And out of this, even if 50% is negative, then your job is done. So I feel that in our setting, we should try to propagate methylene blue as feasible, safe, and ideally suited technique for sentinel lymph node biopsy. And why I'm saying this is because of its reasonably high success rate, excellent accuracy, and acceptable false negative rates. Thank you very much.
Thank you, Dr. Sinu. Can you try to share your video?
Yeah, I will just try again.
Sure.
Yeah. You're able to see it?
Yeah, can you move it to the center? It's
I don't know why it's seen there.
oh, I think
That's
you'll
fine.
have to. Okay.
You
Let's
know,
see if we can. Yeah.
you have to go on
You're
the
able to see it?
We can see it.
Yeah, we can see.
center of your slide.
Okay. But I think it's we can see it. It's
We
visible
can
in
see,
the.
yeah.
So basically the sentinel node concept, this is the dye which was initially used. This is used in most of USA, patent blue violet, mostly used in Europe. And currently we are using the methylene blue, which is available in ampules and vials. Now the dye loading, like we try to load the dye just after the patient is anesthetized. And we inject it before we do the painting and draping, because some sort of a massage occurs while even doing the painting and draping. Use a 24 or a 26 gauge needle. And then if you're injecting intradermal, then we use an insulin syringe and a needle. If you're injecting subareolar, like you can inject wherever you want. I inject it towards the axilla. Just enter into a hollow space, aspirate. If no blood comes, then you load about 2 to 5 cc of the methylene blue. This is the technique which I commonly use, intraparenchymal injection, which I inject it at 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock positions. Now, this is the extremely important part of the procedure, doing a gentle massage of the breast to augment lymphatic mapping. Now, I'll show with breast conservation. The incision has to be given just below the air-bearing area of the axilla, in the middle of the axilla. You may need to give a slightly larger incision as compared to the radiotracer technique. And it is very important to do blunt and sharp dissection to identify the blue stained lymphatics. More often than not, we will be able to identify the blue stained lymphatic, which goes into the blue node. And this is for the purpose of the video. Otherwise, you can use a cautery. If you use cautery, it causes only the staining of the cautery, which may interfere. As I said, always remove with the perinodal fat, brilliant lymphatics. Along with the lymphatic also you can remove. Again with the perinodal remove. This is another patient with mastectomy. I do not like to give the entire flap. I just give the upper part of the incision, which is towards the axilla. What happens is if you expose a long length of the incision, then you get lost. So it is always preferable to open only a small length of the incision. And again, extremely important to look for a blue stain lymphatic. And once you see a lymphatic, you massage the breast, the brilliance of the blue increases quite significantly. Like the normally taken time for sentinel lymph node biopsy failure, as per Giuliano when he described, was about 20 minutes. That was because roughly most surgeons takes about 20 minutes to perform axillary dissection. So if you don't find a lymph node within 20 minutes, this is how, like just below the hair bearing area of the axilla, give an incision more towards the border of the pectoralis major, about maybe a 3 to 4 centimeters incision. And a lot of times you will be able to see the lymphatic. Like here you can see the lymphatic which goes into the blue node. And whenever you don't need find the node, the trick is to look more superficial than deep, more towards the breast. And this is one of the patients who had wire-guided localization sentinel node. In this, I injected the dye under ultrasound guidance, looking at the wire, because I go by the intraparenchymal technique. And again, you can see the lymphatic which is going into the breast and it's going into. And as I said, the lymph node is more superficial than the deep. Like if you don't find the lymph node, always look superficial, always look towards the breast. And removing sentinel node is one part of it. The next important part is the role of the pathologist. And for that, we need to make imprints. We make imprints right in our operation theater and send it to a pathologist. We get the report in about 20 minutes. And that's why I do the sentinel lymph node first and then do the wide local excision. Because by the time I finish the wide local excision, most often the report is available. And if the lymph node is large enough, you can take multiple sections and take multiple imprints. And the rest of the sentinel node, we send it for frozen. And we don't have the frozen section facility in the OT, but we have it right in the same, on the first floor of the same building. And once the frozen section is taken, our resident will be there either, or they will inform us by phone the report of the frozen section. Yeah, that's it. Thank you. Thank you, Arun, for the time.
Yeah. Thank you, Dr. Sinu, for sharing your long experience with blue dye alone technique. I would request you to please be with us for the panel as well as the question answers at the end of the panel as well. So now I would like to invite Dr. Dylan Clark, who has spearheaded the sentinel node biopsy program in the United Kingdom. Dr. Dylan is going to talk about the dual tracer technique, considered to be one of the gold standards in the current times. Over to you, Dr. Dylan. You have to unmute yourself.
Thank you, Vaishali, and thank you to the organizers for inviting me to this webinar. Greetings from an unusually warm and sunny autumn day in Warwick in the United Kingdom. It's really a pleasure to be with you. Sentinel node biopsy is one of my favorite topics. As Vaishali mentioned before, I was involved in setting up the Almanac trial, which was a randomized trial in the UK in the mid-90s. And it's something that I've always been involved in. And I'll probably finish off by, because Vaishali said you would like to see how or hear how I do it. So it's been an evolving process, and I will finish with how I do it at the moment, which may be slightly different from how most people do it. I'm originally from Chennai in South India, and I did my undergraduate and postgraduate surgical training in Christian Medical College in Vellore, and then moved to the UK in the early 90s. Yeah. Okay, just to go back from the origins of surgery in breast cancer. If you look at oncological surgery, surgery in breast cancer is probably one of the few oncological aspects where we've actually got less and less radical as we've gone on. Most other cancers you'd find they've actually stayed the same, whether you look at esophageal cancer, colorectal cancer, they may have got a bit more radical, but in breast cancer, we're exactly the opposite. So if you go back to the turn of the 20th century, we had William Halsted, who introduced the radical mastectomy, which was probably the standard of practice for many years, almost 50 years. And there was a short period in the mid-1950s where we had urban supraradical mastectomy. So in addition to taking out all that Halsted did, he also took out the internal mammary nodes. Fortunately, this lasted only a short time, and from there on, we got more and more conservative. We went on to the Patey's mastectomy, which is classically called the modified radical mastectomy, which we don't remove the pectoralis major, but we either remove or divide the pectoralis minor in this operation. And from there on, in the 70s, we moved to a simple mastectomy. And then, of course, in the 70s, we had Berenice's various trials saying quadrantectomy along with radiotherapy is as good as mastectomies, and then now we've moved to a lumpectomy. However, the conservative surgery has to be followed by radiotherapy, and that's part of the treatment of breast cancer and how we've evolved. Now, if you look at axillary surgery, we've probably followed the same thing. Vani was referring to axillary clearance, which was the gold standard, a level 3 axillary clearance, which was done for a long time. And then we tended to move away from that to an axillary sample. Interestingly, axillary sample was a concept that originated in the UK and became popular only in Europe, and for some reason was never taken up by the Americans, where you take 4 lymph nodes to assess what the status of the axilla may be. And in the mid-90s, this became very popular, and it was shown that axillary sample was accurate in staging the axilla. And then, of course, we've now moved on to what we now consider the gold standard, which is sentinel node biopsy, and I'll come to that in a minute. Now, why did we move away from axillary clearance? The reason for that is because axillary clearances are associated with significant morbidity, seromas, paresthesia, because we divide the intercostobrachial nerve, shoulder stiffness, which is obviously because you've operated in the axilla, pain, both involving the limb and the distribution of the intercostobrachial nerve, and probably most worryingly, lymphedema. Now, the reason why we wanted to move away from more drastic axillary surgery was actually the success of the screening program in the West. We found that with the onset of the screening program, more and more of our patients were node negative. So we reached a stage where we were doing an axillary clearance for all our patients, and only 30% of them were axillary node positive. So in 30% of patients, we got the information we needed, but in 70% of patients, it was a negative axilla, and we left them with all of this morbidity that was probably completely unnecessary. When I first moved to the UK in the early 90s, it was not uncommon to see a patient like this in the outpatient department. She's had a radical mastectomy. You can see a deformed, disfigured chest wall, a stiff, frozen shoulder, a painful and lymphadematous left upper limb. And this is the reason why we are trying to move away from an axillary node clearance, especially in patients who are node negative. And that's where, so why do we do axillary surgery? Vani alluded to this. We need to stage the axilla accurately. And hence, a clearance was a good way of doing it. But unfortunately, 70% were node negative, so it was of no use to them. Secondly, the staging of the axilla helped us to show whether the patient's disease was just local, i.e. localized to the breast, or was this loco-regional, where it had spread from the breast to the regional lymph nodes? And based on this information, we actually plan our adjuvant treatment. So it's important to know what the axillary status is, i.e. is the axilla positive or negative, to decide whether this patient needs additional adjuvant radiotherapy, additional chemotherapy, and if so, what form of chemotherapy. And of course, in those patients in whom the axilla is positive and you do an axillary clearance, it's obviously a therapeutic operation where you remove the disease. So axillary surgery is necessary. However, we found that axillary clearance was an overtreatment, and that's where sentinel node biopsy comes into its own. So what exactly is sentinel node biopsy? The word sentinel is defined in the Oxford English Dictionary as a sentry or a guard or one who keeps watch over. So if you translate this definition to a breast cancer and the local axillary nodes that that's draining to, the sentinel node will be the guard node or the sentry node or the node that keeps watch over the tumor. So if you have a breast tumor here, the tumor cells will get into the lymphatics and get trapped by that guard node or the sentinel node before it spreads anywhere else. And of course, then we had the historical evolving of the sentinel node biopsy within breast cancer. Seenu has given us a good overview about the history of sentinel node biopsy. And as he quite rightly mentioned, a South American surgeon called Raymond Cabanas first introduced the concept in the 1970s, but he didn't introduce an intraoperative assessment of the sentinel node. Cabanas actually, with various lymphangiograms in penile cancer, showed that the sentinel node in the inguinal region was an anatomically constant node, and he dissected that node out, an anatomically constant node, rather than an intraoperative assessment of the sentinel node. The concept of the intraoperative assessment of or localization of the sentinel node was brought in by Donald Morton, as Seenu alluded to. And then, of course, Morton and Giuliano were in the same institute. So Morton went up to Giuliano and said, hey, I've got this new technique which I'm able to localize a sentinel node. You want to try it in breast? And Giuliano said, oh, why not? And so he started doing it in breast cancer. And then we had his seminal publication in 1994 in the Annals. And Giuliano himself actually said that was one of the mistakes he made, was publishing that paper, because his localization rate at that time, as Seenu just alluded to, was only 65%. So when Giuliano got a low localization rate, we had David Krug, who was one of the surgeons in Vermont in the east coast of America, who said, let's see if there's something else other than the blue dye that we can use. And he came up with the concept of using a radiopharmaceutical. So Krug started using a radiopharmaceutical, a radionucleotide, and he produced better results than Giuliano, but still hadn't got to anywhere close to 100%. And then, of course, we had Charlie Cox and Doug Reinken, Charlie Cox being a breast surgeon and Doug Reinken being a melanoma surgeon, both of them working in Tampa, Florida, who actually showed that if you used a combination of blue dye and an isotope, your localization of the sentinel node was close to 100%. And that's where we get our combination concept, which then started the whole localization in sentinel node biopsy in breast cancer in the mid-90s. So does the concept work? There were various randomized clinical trials that showed that it definitely works. The first one was published by in Umberto Vernesi in the late 1990s in the NEJM with 500 patients. We then had a large number of randomized controlled trials, the Almanac being the one that was done in the UK, along with Ani Purushottam's Cambridge trial. But all of them used a combination technique, and the combination technique then became the gold standard. And when we were all taught how to do the technique, we were all told that the combination technique, quite rightly so, as shown by these randomized controlled trials, was the best technique to localize the sentinel node biopsy with a very good localization rate and a low false negative rate. And hence the combination technique is still considered the gold standard, and that's what we use now. So what do we use in the UK for the combination technique? We use a radiopharmaceutical, which is nanocol, which is basically human albumin labeled with technetium-99. When we started doing this, we used 40 megabecquerels, but now we've gone down to 20 megabecquerels if we'd done the day before, or 10 megabecquerels if injected on the day of the surgery. Again, we used to inject them peritumorally but we now move to either an intradermal or subareolar injection. What are the advantages of, what are the downsides of radiopharmaceutical? My previous speakers have all alluded to that, so I'm not going to go into that. But fortunately, in the UK, we don't have as much of a problem with a hot lab and nuclear medical facilities, because most hospitals in the UK, even the district general hospitals, will have nuclear medicine facilities on site. And so it's not so much of an issue. And so we still continue using it. One of the problems with radioactivity, when we first started using it, could it be dangerous to the patient? Could it be dangerous to the operating personnel? Could it be dangerous to the relatives around the patient in whom it's injected? Could it be dangerous to the healthcare workers? And numerous studies have been done in the 90s to show that actually the amount of radioactivity exposed to the patient or to the surgeon is extremely low. And this is an extremely safe amount of radiation that's used, so it's not a worry. And then, of course, you have the issue, especially in the UK, where disposal of radioactive waste we have to be very careful about. And there are various stringent rules on how you dispose radioactive material, even though the sentinel node, which has the most radioactivity, and the tumor and what's around it is sent off to the pathology lab. The gauze pieces, the sterile drapes that we use, all of them have to be processed as if they have some radioactive contamination. This is a picture of injecting of the radioactive isotope. This was done peritumorally, as I told you earlier. When we started off, we used to use these lead syringes, lead syringe guards to try and protect our fingers, but all of that is now history because we know it's very limited. And we then started doing lymph scans. Initially, you could do a dynamic or a static scan. The NHS being slightly cash-strapped, we did static scans, which was performed a few hours after injection of the radioisotope. The acquisition time was 3 minutes or 180 seconds, where the gamma camera is used over the axilla. And we started with oblique and anterior views and often had a skin marker placed over the hot node. This is what a lymph scan shows. This is the area of the injection, where the radioactive isotope is injected, the large blob, and this is the small blob showing you the hot node or the sentinel node. This one has just one, some of them have two, and as Srini showed, sometimes you can get quite a few of them depending on how long later. Blue dye was the other thing that we used. Srini's already alluded to a lot about this. In the UK, we use patent blue V, V standing for violet. Other things that have been used are isosulfan or methylene blue. We use 2 mL of a 0.5 solution, and I normally inject this after induction and before we drape and prep the patient. I injected periareolar and subdermal and a massage. Controversial by some, but I tend to use it very much like Sinu. I don't think you lose anything, and it's well worth using. Problems with blue dye. There are a few issues with the blue dye. The main advantage, as Sinu's already alluded to, it's extremely easily available. And the issues with the blue dye is obviously anaphylaxis. In the Caucasian population, in patients who are very fair-skinned, often they look cyanosed post-operatively, and in one of my first operations, I had to, the anesthetist got all worked up and he felt that we had caused a pneumothorax during a mastectomy. So I had to tell him, do a chest x-ray just to show him that it wasn't a pneumothorax, it was just the blue dye that is taken up in the circulation. Patient appears cyanosed or slightly blue. And apart from that, you have the anaphylaxis and a drop in the oxygen saturation that Sinu had alluded to. The other downside to the blue dye is it's extremely messy. The injection site gets messy, the tissue planes get extremely messy, especially if you're doing skin-sparing mastectomy, where it's quite important to have clean, nice tissue planes, and the blue dye interferes with all of that. So blue dye, even though it's now the standard procedure, I've moved away from using it in my personal practice, but it is still the gold standard. I'll quickly show you, I don't know if I'll have problems like Sinu had, but I'll try and see if I can show you a video of a short procedure, how we use the blue dye. This was just 2 minutes and showing you the gold standard of how we do this. Sorry, let me go back. This was taken about 20 years ago, so it's quite old and quite a few things are changed, but the basic concept are still the same.
The technique of sentinel node biopsy involves
Can you hear the voice?
And blue dye around the breast
Yes.
Yeah.
The isotope and dye then travel in the lymphatics to the first level or lead node, so-called sentinel node, and this is detected by sight or a handheld probe which records gamma radiation. Here we see the injection of the isotope around the tumor. This is technetium-99 with albumin as a colloid and is injected at 4 points around the tumor. After the injection of the isotope, a scintigram is performed on the gamma camera, and an example is shown here. The large dark area is the site of the injection, and the smaller hotspots are due to the sentinel nodes, as we can see in this scintigram. At surgery, a blue dye, patent blue 5, is injected again around the tumor, and this is done at induction around 5 to 10 minutes before the skin incision is made. Then the surgeon opens the axillary fascia and looks for a blue-filled lymphatic or a blue node, and also scans the axilla with the gamma probe shown here to detect any high counts within the axilla. Here we can see a blue node with a lymphatic leading into it, and this is indicative of a sentinel node. Here we can see the probe being used to scan the axilla for hotspots, with the counts being registered on the window of the machine. As the probe approaches the hot node, the counts rise and the sound pitch also rises. Therefore, the surgeon can simply listen to the noise as he is scanning the axilla without having to look at the machine. Once the sentinel node has been removed, the counts that it contains are recorded away from the patient, as this will reduce the background radiation coming from the very hot area around the primary tumor.
Okay, I'll stop that there. That's just to demonstrate how we do a sentinel node biopsy and the use of the probe. Now, just to go through a few things that have been touched on before. In my mind, if you wanted to maximize the benefit of a sentinel node biopsy, you should have a reliable intraoperative assessment. And that is probably the most important aspect of sentinel node biopsy that I've been working on in the last 10 or 15 years. There are various advantages. Obviously, the advantage to the patient, if you have a reliable intraoperative assessment, you then get the result intraoperatively and you do an axillary clearance at the same time in the 25% of my patients in whom it's positive. If it's negative, you don't have to do anything further. More importantly, if it's sentinel node, if you then get the results the same day, you can go ahead and treat the axilla if it's positive. And then when they have chemotherapy, that starts much earlier than if you had to go back for a second operation. Benefits to the surgeon, obviously, it's much easier to do an axillary node clearance at the same sitting rather than going back into scar tissue. And if you're an insured patient, or if you're paying, the patient is paying themselves, it saves you the cost of a second operation. Unfortunately, in the UK at the moment, 90% of the hospitals in the UK still do a pathological H&E assessment of the sentinel node and go back for a second operation if it's positive, which I think defeats the whole purpose of the sentinel node biopsy. And so in Warwick, where I work, we do an intraoperative assessment of the sentinel node. We started off like Sinu doing the touch imprint cytology, but in literature, you'll see that the touch imprint cytology has a very low sensitivity rate. By nature of the technique of how we do it, you can miss tumor cells between the sections where you do an imprint. And so having started this in Warwick, we quickly moved away from it. The other option is a frozen section analysis, and this is the gold standard. However, this is labor intensive. You need a pathologist, you need at least 2 lab technicians, and it takes up time. So in the UK, in the National Health Service, this is almost a no-go area. The pathologists are not willing to do this, and so we cannot do a frozen section analysis and hence histopathology. But what we've started using is molecular assays, which in my mind is now the new gold standard for assessing the sentinel node intraoperatively. And what I have been using is something called OSNA, which stands for one-step nucleic acid amplification. And the company that makes this is Sysmex. We also have another company that makes Johnson & Johnson, which makes a similar thing called Gene Search or Medicine. What I use is OSNA, and this is basically an intraoperative assessment using a molecular assay. The technique we use is reverse transcriptase polymerase chain reaction to detect metastasis, and we use a single molecular marker, which is cytokeratin 19. We know that cytokeratin 19 is only seen in breast cells or in breast cancer. So if you detect cytokeratin 19 in the lymph node, it has to have come from the tumor, and hence this patient is positive. The other advantage of OSNA is there's no purification of the mRNA needed, so it takes a shorter time to do this. And this is just a cartoon to show you how we do it. The sentinel node is completely homogenized. So the whole sentinel node is homogenized, and then that is centrifuged and put into the machine, which then amplifies the mRNA and detects whether there is any cytokeratin 19 within that. This is the machine that we use. We have 5 wells within that machine. So you can use 5 nodes in one single run, and usually it takes about 30 minutes to get the results. The results come up on a monitor, on a screen, on a computer, and it's reported as 1 in 3 ways. You can either have 2+, which means it's a macrometastasis. You can have 1+, which is a micrometastasis, or you can have a negative, which is dependent on the copy numbers. So within half an hour, we get a phone call from the pathology lab saying it's either macrometastasis, a micrometastasis, or it's negative. In the UK, we do not treat micrometastasis detected on OSNA as node positive. We regard them as node negative. So if my patient has a macrometastasis, I will go ahead and do an axillary node clearance. All other patients do not have any further surgery. This is to just show you 800 patients that have been subjected to OSNA, and only 17.3% of these patients go on to have an axillary node clearance. The rest of them are either micrometastasis or negative, and so have no further treatment. So just to summarize, how do I do axillary staging? I'll go through this in a few minutes. All our patients at the time of their triple assessment have the ultrasound of the axilla. And if there are any enlarged nodes or suspicious nodes, they have an axillary fine needle aspiration or a co-biopsy. If the axillary node is positive, they go on to have an axillary node clearance, which is about 20% of my patients. In the triple assessment, either if the axillary nodes are not enlarged, or if they're enlarged and the fine needle or co-biopsy comes back as negative, we proceed to do an sentinel node biopsy, which is done as I've mentioned to you before. How do I do it? I use radioactive isotope, nanocol, 20 megabecquerels the day before surgery, which we inject intra or subdermally. This is done by the radiophysicist rather than by the surgeons at all. Because of resource limitations, I've skipped a lymphocyte scan. I don't do that anymore. And then on the table, as soon as the patient is put on the table, before they are anesthetized or before they are draped, I go and use my gamma probe through the skin to detect whether there's a hot signal or not. If there is a signal, which there is in about 95% of my patients, I do not bother with a blue dye. And if there is no signal, I then use patent blue, as I described earlier. And the operation, like Sinu said, starts with the sentinel node biopsy. I remove the sentinel node and send it off to the pathology department for an OSNA analysis. The other advantage of the OSNA, intraoperative OSNA, is you do not need a pathologist to do it. We have now trained our lab technicians in our pathology department, and they do the OSNA completely without any pathologist involved in this, and they phone me in about half an hour to say whether it's positive or not. While they're doing that, we do the lumpectomy or the mastectomy, and if it's OSNA negative, that's the end of the operation. If it's OSNA positive, we go on to do an axillary node clearance. So that is, in a nutshell, all that I have to say about sentinel node biopsy and how I do it, or how we do it in the UK with the intraoperative assessment using a molecular assay called OSNA. So just to finish, I'd like to show you that we've come a long way from 30 years ago when I came to this country, where this was the standard. Almost every other patient came like this. I'd just like to show you patients now. This is one of my patients who's had bilateral breast cancer. On the left side, or her left side, she's had a skin-sparing mastectomy with an immediate reconstruction, and she had an axillary clearance. This was in the early 2000s. 5 years later, she had a cancer on the other side. She's had the therapeutic mammoplasty with a sentinel node biopsy, and this is the sort of result we'd like to see in our patients who we treat with breast cancer. The next patient is a lady who's had bilateral mastectomies with a nipple-preserving skin-sparing mastectomy and an immediate reconstruction with Braxton and an implant, and she is an extremely satisfied patient. So with that, I would like to thank you for your attention. And if there are any questions, I'd be happy to take it. Thank you.
Yeah. Thank you, Dr. Dylan. Actually, we are going to have a panel discussion. So you're going to be the panelists, and we'll take up, Dr. Goel is going to moderate the panel discussion, and I would invite, along with four of you, three more panelists. Dr. Selvi, who is an oncoplastic breast surgeon at Chennai Breast Center, Chennai. Dr. Tushar Zadav is an oncoplastic breast surgeon and a surgical oncologist in Mumbai. He's the founder of Mumbai Breast Care Center, and Dr. Veda Padampriya. She is an oncoplastic breast surgeon working at MGM Healthcare in Chennai. So welcome panelists, and over to you, Dr. Arun Goel.
Thank you, Dr. Vaishali. First of all, big thanks to all the four speakers. In fact, they've done a great job and clarified a lot of issues which I was thinking of addressing in the panel discussion. So I believe the audience would have got a lot of messages. So still I'll try to keep it as short as possible. So I'll first start with Dr. Clark. Dr. Clark, are there any centers in UK where nuclear medicine is not available and they do breast surgery?
Yeah, interesting question. My own center does not have a hot lab in the hospital, Arun. So we use the hospital, which is 10 miles away, and hence all my patients have the injection the day before rather than on the day of surgery. So my closest hot lab is 10 miles away. So patients go to the hot lab the day before the operation, have the injection of the radionucleotide, and then come to us on the day of surgery the following day.
So as part of the national policy, every patient who's operated for breast cancer and has to have sentinel node biopsy will have a dual tracer approach in UK, whether it's in the hospital or outside?
Absolutely, yes. Unless I've moved away from dual tracer where I've dropped the blue dye, unless I can't find a node on the isotope with the gamma probe. But otherwise, the standard is still everyone has a dual technique sentinel node biopsy.
And the centers where they are not doing intraoperative assessment, are they doing the sentinel node under general anesthesia or under local anesthesia?
Still, it will be done as part of the operation for their breast cancer treatment. So they will have a wide local excision stroke mastectomy along with the sentinel node biopsy. The sentinel node is then assessed by histopathology, which is H&E, and we get the result a week to 10 days later. If it's positive and if they have then other tumor characteristics which don't fit into no further treatment for a positive sentinel node, they will then come back for a second operation where they have the axillary node clearance.
Okay, and there was a question from the audience. Since the node is totally used up in OSNA, we don't get any information about extracapsular extension.
That's a good question. So what we do is, what the technicians do is, before they put the node into the OSNA machine to be homogenized, they trim all the fat around the node and put just the node in. The fat around the node is then assessed by H&E.
Okay.
But Dylan, how do you do histopathology of that sentinel node?
There's no histopathology. The node is completely assessed with OSNA. That's it.
Okay.
So there is, like, you're so comfortable with OSNA that if it is positive, it is positive?
Absolutely. It has been validated in the turn of the century, 2000 and 2004. There were validation studies to show that OSNA is absolutely reliable. And if OSNA is positive, there's hardly any false positives. So we don't need to use H&E at all. So the whole node is now subjected to molecular assays.
Yeah, but you won't have any slides where if you want to do some retrospective study, look at it, it won't be possible, no?
That is one of the downsides, is we've lost all tumor tissue. Yeah, all the tissue is gone.
Actually, we do MR spectroscopy. Sorry, we do MR spectroscopy of the sentinel node, and we face the same problem. Since MR spectroscopy is not like as validated as OSNA, we just send one half of the node for MR spectroscopy. But the problem with that is, if there is one focus in the other half of the lymph node and this, then it will come negative. That is the problem we have.
So what is this micrometastasis, Dylan? You used up the whole node. It's just a micrometastasis. What's the pickup rate there? And if it is, then you're going to end up doing a clearance for a micromet.
No, I've mentioned in the talk that micrometastasis in the UK are treated as node negative. So we do not treat micrometastasis on sentinel nodes in the UK as node positive.
If you're doing OSNA,
yeah.
So how are you going to evaluate that?
OSNA is reported as 3. It's reported as positive macrometastasis, positive micrometastasis, or negative. Those are the 3 reports I would get at the end of the phone. So they will tell me either as positive macromet, and they'll give me a copy number. If it's more than 5,000, it's a macromet. If it's positive micromet, they will again give me a copy number. And if it's negative, they will say less than 250 copy number negative.
Does the lab technician need some training?
So they have, it doesn't take long. The company comes out and trains the lab technicians just in one day. They're up and running. And then for the first, I think 20 are supervised by the company to make sure they're doing it properly. And then after that, now for the last 10 years, our lab technicians have been running the machine without any problem.
So if I may again counter question that, so what is the cost effectivity of doing OSNA versus having a pathologist there in the frozen who's evaluating the node for a macromet and giving us a report?
Sorry, can you repeat the question again, Vani? I didn't.
What would be the cost effectiveness of running OSNA versus doing having a routine pathologist running a frozen section and giving us a macrometastasis? So I am not very sure, because it's not going to be very useful for the Indian setup at all.
Yeah. So
what is the cost of the machine?
Cost analysis is not comparable, because in the UK, we cannot get a pathologist to do frozen section, period. They will not do frozen sections. We do not have the manpower to do the frozen sections that we need.
Absolutely. So
what is the cost of the machine? What is the cost?
It's
cost of the machine is 50,000 pounds, and then the reagents for each patient is about 200 pounds.
Okay. Dr. Clark, there was a question. Can you use half of the node for OSNA and save half for pathology? Is that viable?
It's doable. In fact, the validation studies Arun first did every alternate slice. They used to slice it in very small 5 microns, and alternate slices would be used for one or the other. Now, if you had research reasons why you wanted to do that, that's fine. But otherwise, it doesn't seem you're just duplicating everything by doing.
And then now I will move to Dr. Vani. So, Dr. Vani, the standard of care, say at Tata, is a low axillary sampling with a frozen section?
Yes.
Okay. And let me ask you, a peripheral center, say you have in Sangrur, do you have a frozen section facility there also?
I think it's available everywhere right now. We don't have a proper frozen section in any of the centers that have been put up by Tata.
Okay. Okay. That's wonderful. So your message would be that low axillary sampling would become probably a technique which can be used in every center anywhere in the country. A pathology support definitely would be important.
Yes, and I don't think it's such an intricately difficult procedure to get a frozen section in. We have pathologists who are getting trained. So there is actually a national cancer grid which also helps to train everybody in every center.
Okay.
So there is a good training that is ongoing, and I think it's a very simple procedure which can be learned easily. The learning curve is very short. A surgeon who knows how to operate would know how to do axillary sampling. It's as simple as that. Of course, one has to take care that you don't injure the nerves. So you have to take care of that. I think that's absolutely easy procedure.
Vani?
Yes?
Yes, in here. Like, though I'm a strong proponent of sentinel lymph node biopsy, I'm really fascinated by the low axillary sampling, because I feel low axillary sampling, it has definite anatomical boundaries.
Absolutely.
I know that there is an intercostal brachial now. Medially, you have the serratus, laterally the latissimus, and inferiorly where both of them join. So I feel that if, like in our country, people can't practice sentinel lymph node biopsy, at least they should start practicing low axillary sampling, I feel. Targeted low axillary sampling, and then maybe they can move on to sentinel lymph node.
Yeah.
It's not that there is a hierarchy here. It's not a gradation that you can start by low axillary sampling.
Or it can be definitely a permanent choice.
Permanent choice. Why not?
Not progress to sentinel, as if sentinel is an advanced technology. It's a blue axillary sampling that can be done, or you can do a non-blue dye guided. Either ways, the sentinel node or the blue node is always within the sampling area.
Okay.
In 80% of the cases.
The false negative.
Because sentinel node can be level 2 and level 3 also.
Exactly. It can move anywhere else also, in which case you're definitely going to get a false negative rate.
Yeah.
Right? High false because you won't be identifying them correctly, but low axillary sampling definitely shows us the blue lymphatics. You are able to identify the node correctly. You have the exact number of count. You can palpate the nodes there and then, and you can send it to the pathologist.
Okay.
I feel there are level 2 nodes. About 20% of the patients will have level 2 as sentinel node.
Somebody asked for the lymphedema rate. It's a 3% versus 6%. So if you see it's 3% for sentinel node and 6% for the low axillary sampling. So it's actually an acceptable procedure, very easy to do, and I don't see any harm.
Dr. Vani, does the pathologist process all the nodes in the specimen or only 3 or 4 nodes and then?
So we have a minimal count. We need 4 nodes at least. So the 4
we need 4 nodes
have to be processed. So there is obviously, when you have the fat being processed later on for histopathology and the separation or identification of very tiny nodes come up. So you may get a count which is saying 7, but it doesn't mean these are 7 significant nodes, because there may be absolutely 2-3 millimeter nodes as well, which are separated out when the fat is processed to separate all the lymph nodes. So there is a small area that we pick up. It's anatomically bound, as Sinu has already said that.
I think now I will move to Dr. Selvi. Dr. Selvi, you have also experience with blue dye alone and you are using it in your practice. So would like your statement about using blue dye alone and how would you recommend it to other breast surgeons?
I started doing sentinel lymph node biopsies in 2007. I validated because the pathologists were new here at that time. And we did 20 patients with both axillary clearance and blue dye directed sentinel lymph node biopsy. And then we started doing blue dye directed sentinel lymph node biopsy. And then 2 years down the line, we did get the radioisotope gamma camera. And then I did with dual technique. And then I started operating in another hospital where the gamma camera was not available, and then switched back to using only blue dye. And since from I think 2013 or 14, I've been doing only blue dye directed sentinel. Occasionally, when I do a post-NACT sentinel lymph node biopsy, not always, but sometimes I ask for a gamma camera. We borrow it from the other hospital. So otherwise, it is, see, logistically in Chennai, I don't know what cost in other places. It adds to 30,000 if you use a gamma probe. So the cost of the gamma probe rental that you pay to the hospital, and the injection, the radioisotope injection, the cost of the injection, as well as the cost of the physician who's injecting, the radioisotope department. So all of this adds up to 35,000 to your surgery. And so therefore, one or the other reason I stopped using dual technique and I now do only with blue dye. So it's since 2007, I've been doing sentinel lymph node biopsy. We've analyzed our data too. We've had I've had one recurrence with a patient who was sentinel lymph node negative, who had only axillary recurrence. So we've had a couple of other recurrences who had not only regional but systemic as well. But I had one patient who had only regional recurrence, no systemic, no local recurrence. So this is in about 700 sentinel lymph node biopsies from 2007.
So Dr. Selvi, what is your failure of identification rate, say, with blue dye alone?
Exact number today, unfortunately, I didn't look it up. But when we looked up for a presentation earlier, 3 years back, was 5%.
Okay, thank you. Dr. Tushar, can I ask what is your current approach to sentinel node biopsy, and maybe a little bit about the learning curve that you have gone through or you feel others should?
Yeah, definitely. Actually, I will explain you the situation in Mumbai, actually. Not many hospitals, am I audible?
Yes, you are.
Yeah. So not many hospitals, even private hospitals across Mumbai have the nuclear medicine departments.
Yes.
And even if they do have, they don't have gamma probes. There are a lot many examples of that. So actually, we cannot offer the patients the sentinel lymph node biopsy based on nuclear dye techniques. Especially even the private sector does not have ICG technology yet at present. So if we have to give some options of like dual dye sentinel lymph node techniques to the patients, we have very limited options and very limited centers across the Mumbai. And the second burning issue here is the distance. Actually, the Mumbai metropolitan region which comprises of about 9 municipal corporations stretched over 4,000 square kilometers. The patients do not travel from one end to the other. Now, if in the view of limited centers and huge patient load, these patients do not travel from one end to the other for the sentinel lymph node biopsy. I have come across so many patients that I have counseled them for the sentinel lymph node biopsy, but somewhere nearby local area, they found out some surgeon and they have completed the axillary clearance with minimum cost. So that is another issue, is that the distance, they don't want to travel, though the option is given. And the third is the cost. As Dr. Selvi pointed out, it actually adds up around 40 to 50,000 in Mumbai region for the sentinel lymph node techniques. Now, the people here can offer even MRM in 50,000. And if they have to add the 50,000 more for sentinel lymph node biopsy, it is actually not cost effective. So it is very difficult to tackle these situations in Mumbai region, especially the distance, cost, and the availability of the centers. So the vision of our Mumbai Breast Care Private Limited is to give the quality care to accessible, that is accessible as well as the cost-effective quality care to all. So that's why we have tied up with many centers as a Mumbai Breast Care Private Limited with other centers who are actually feasible to give the indoor facilities. And we have shortlisted the lacunae of those centers. And we tried to bridge the gap by, like, let's suppose for one institution is having a nuclear medicine department, but we have our gamma probe. So we actually travel with gamma probe to that institution. Some institutions are not having nuclear medicine department, but in that area, there are nuclear diagnostic centers. So we have a tie-up for the dye storage as well as the dye injection with that center, nearby center, so that the patient gets admitted in the morning, get a dye at that center. We actually facilitate its transport to that center and complete that. And if it is not possible, then we offer a low axillary sampling.
Low axillary.
Yeah. So whenever it is not possible to go ahead with the dual dye technique sentinel lymph node biopsy, we offer a low axillary sampling to that patient. So these are the two which we are actually practicing here right now.
I think Dr. Tushar has highlighted the problems which surgeon is facing in a city like Mumbai. And we are only talking of the major metros of the country. And when we move to tier 2, where a lot of work is being done, so we have to definitely propagate these approaches more strongly. Dr. Veda, say you have moved recently to Chennai. So in your facility, what is the infrastructure available for sentinel node and what do you do?
I've had the advantage of working in different setups. So when Rajiv Gandhi, it used to be like you have the luxury of the nuclear medicine department and the lymphoscintigraphy. And even there, when the nuclear medicine department was down for renovation and the gamma camera was not there, we had to resort to blue dye alone. That was as early as 2013 and 14. And when I shifted to Max, Shalimar Bagh, initially we didn't have the nuclear medicine set backup. So what we used to do is we used to get the gamma camera from either Vaishali or Saket, and we used to get the patient injected at the nearest nuclear facility. That is within 2 to 3 kilometers. And that is as recent as maybe 2017. And the time I shifted to Chennai, it's been most of it is COVID crisis. And then there was because of logistic issues, we were not able to procure the radiopharmaceutical. So, and luckily I had the ICG backup. So we've been using ICG and methylene blue as this thing for sentinel lymph node.
Okay, that's wonderful. Sir, Dr. Kopikar, you said you have started using ICG alone. So do you feel ICG alone would be equivalent to say ICG plus blue dye?
Well, I think so. Well, there is no real, except the Mox paper that he showed, there he has used only ICG. So basically, yes, I think ICG alone would suffice, and it would prevent that, complete staining of the operative field, as well as the chances of the skin necrosis, which can happen with blue dye. And just as a comment to all the people who believe that this may not be cost effective, I believe that in a good department of a multi-speciality hospital, the spy camera can be used in various departments for liver resections, for bowel anastomosis, for bile duct injuries, for so many things. So basically, it's a multi-purpose sort of equipment which could be there in a multi-speciality hospital, and therefore the ICG dye itself costs only 1,500 rupees. And in my center, I think the whole sentinel node biopsy with ICG costs the patient around 10,000 rupees. So basically, and one more advantage is that the control of where to inject the dye is totally in the hands of the surgeon, rather than relying on some technician or a nurse in the nuclear medicine department. And where sometimes you may have to inject a little bit more quantity, or maybe you may have to change the location of the injection depending on where the tumor or an incision lies. So therefore, there are certain advantages of ICG practically which I have been starting to notice, and therefore I think probably it could be a cost-effective measure in a country.
The question is, what is the cost of the spy camera you have purchased or acquired? So if you can give some ideas.
So the spy camera costs between 55 to 60 lakhs. I think we got it for around 55 to 60 lakhs, but it can. So with if you are doing around 20-25 procedures, even at 10,000 rupees per procedure, I think within 2 years it becomes cost effective, and there could be many more procedures if it is used by various other departments.
And I think we have some work by Dr. Somashekar where they have developed some indigenous camera, and though I have not seen it in operation, let's see if it comes out, becomes widely available. I think since we have already overshot. Yeah, Dr. Shah?
That system is very cost effective, sir, that Dr. Somashekar which developed.
Okay.
It is actually the same technique which comes around 30 lakhs.
Okay,
yeah,
wonderful.
The only thing is it has a little less sophistication. The camera
I
is
understand
not
that.
powerful, and it doesn't have the color overlays, so it doesn't have the 3 modes. It's only got the 5.
So I think since we have already overshot the time, I would like to stop the panel discussion here.
Last comment that I would like to give.
Yes,
and look at all the discussions, no matter how attractive a technology sounds or is, there is a very clear factor of cost that comes in, and that cost is kind of non-doable for majority centers.
Yes.
I don't see where we'll be able to accommodate all this, and I guess the low axillary sampling still remains a very attractive procedure for all centers across the board, irrespective. And you can actually control the amount of excision that you do because it's a surgically controlled procedure. It's not dependent on any kind of other technology, and it's the best low-cost technology as I see, with a very good results, even in the post-adjuvant chemotherapy status.
So
you should give a chance to all speakers. If Vani has said, then you should give chance to all speakers.
Yeah, I think I can make a summary here. I believe that low axillary sampling and blue dye alone are viable methods, and for wider adoption in the country, any center which wants to do breast surgery should not do axillary dissection for CN0 axilla. They should start adopting this. In the initial few cases, they may use it for validation and then proceed to using it as a decision-making tool. As Dr. Sidhu pointed out, there may be a failure of identification if it is 10%. Also, the 90% of the patients would benefit from this approach or low axillary sampling. So, and centers which are, say, large multi-speciality hospitals would be investing in an ICG camera where it becomes used by multiple departments. So there you could apply it without having to resort to nuclear medicine. So multiple options. I think we should keep on developing. The approach should be no patient should be offered axillary dissection for a CN0 axilla. That is the message I would say as a takeaway. There are some questions about imaging and all. I would say that we are going to plan some future events on axillary imaging and pre-operative assessment with FNAC, and also we would like to cover those issues there. And once again, thanks a lot to all the faculty and all the audience. It was a wonderful session. And Dr. Vaishali, anything else you would like to add?
No. Again, I would also like to thank the speakers, the panelists, and the participants. And I'm sure they've enjoyed today's webinar. And we promise that we are going to bring up some more such topics in the upcoming webinars. We would let you know as soon as we plan the next webinar. Thank you so much and have a great day. Thank you, Dr. Vani, and have a great birthday. Thank you.
Happy birthday, madam. Yeah.
Thanks, Dr. Gopika.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you all.